Good morning all. Session will start within few minutes.
Hello. Welcome everyone. Thank you for joining us for today's webinar. Myself, Dr. Asmita Bhadre, Assistant Professor in Comarbhutya Department and also Organizing Coordinator. A very warm welcome to all for the national webinar on neonatal care and nutritional disorders in children. Organized by our principal and Comarbhutya Department, Dhanvantari Ayurved Medical College and Charitable Hospital Udgir. The session will be start within 5 minutes.
या पंकज सर या उधर तुमका सर सजा दिए ठीक है हो आना सर ये वीडियो सर बोला बड़े अरे बालाजी
Welcome everyone. Let's start the webinar with Dhanvantari Pujan. I request Dr. Datta Patil sir, who is Principal of Dhanvantari Ayurved Medical College and Hospital Udgir for Dhanvantari Pujan. And also Pujan of Vaidya Prata Joshi sir's image, who was renowned Ayurved specialist and Panchakarma specialist Dhule.
फोटो का दे राघु मोर
शंखं चक्रं जगौकां दधमृतघटं चारुदौर्भिश्चतुर्भिः सूक्ष्मस्वच्छातिरुद्धं शुकपरिविलसन्मौलिमम्भोजनेत्रं कालाम्भोदोज्ज्वलाङ्गं कटितटविलसच्चारुपीताम्बराढ्यं वन्दे धन्वन्तरिं तं निखिलगदमिव प्रौढदावाग्निलीलम् प्रौढदावाग्निलीलम्
परम पूज्य आदरणीय डॉक्टर प्रता जोशी सर, इनका कल दुखद निधन हुआ है, तो हमारे गुरुवर्य को एक 2 मिनट की मौन रख के हम श्रद्धांजलि अर्पण करेंगे। मैं सबको विनंती करूंगा कि 2 मिनट का मौन रखें। थैंक यू सर। मैं भगवान को प्रार्थना करूंगा कि डॉक्टर प्रता जोशी सर की आत्मा को शांति मिले और उनके परिवार और उनके सभी शिष्यजनों को ये दुखद घटना सहन करने की ताकत दे।
Welcome once again. First, I heartily welcome our inaugural function guest, Honorable Dr. Zubair Sheikh sir, who is Vice President of CCIM and BMS LLB LLM PhD scholar and member of COVID Task Force, Government of India. He is also a member of National Council for the Clinical Establishment, Delhi. He is a member of Ayurveda Siddha Unani Drug Regulation Committee, FDA, Government of Maharashtra, and also member of National Tuberculosis Elimination Program, Government of Maharashtra. He is ex-member of MCIM and State Hajj Community, Government of India. I also welcome our second chief guest, Honorable Dr. Santosh Neopurkar sir, President Ayurved Vaspit of India. He has completed BMS from Government Ayurved College Nanded and PhD from Tirak Maharashtra Vidyapit Pune. He is member of National Council for Clinical Establishment Delhi and also member of Scientific Advisory Group CCRAS Delhi. Sir published a Rukshavalli Guni Soire book. He got many awards like Bhavani Shankar Ayurved Puraskar, Shankar Daji Shastri Karyakarta Puraskar, Ananta Shri Puraskar, etc. I request Dr. Zubair Sheikh sir for inaugural speech.
Very warm good morning to everybody. I am very much thankful to organizer of this today's webinar, Neonatal Care and the Nutritional Disorder in Children, especially Dr. Datta Patil sir for giving me opportunity to join this program. Organizing any webinar is not an easy task. There's a lot of problems there in the, you have to be behind all the speaker to be on the time, to be particular about the connection of the, there are many nightmares while organizing the webinar. First nightmare is because the speaker may be sometimes difficult to co-op with the program, but I hope that today's speakers are very competent. There is a poor attendance, but I have seen just now, there is about say 660 people have joined the webinar today. Attendance. Another is a background noise is always problem because many people are not able to mute themselves. Another problem is the engagement with while the connecting with the question answer also was very difficult. And the third very problem is the internet connection is very big problem with the webinar. But today's webinar is going to be very successful because the organizers have already organized last time also. It was a very big success. First, I will go for the neonatal care. Neonatal care is a very big topic, but my speakers today will be definitely going to cover all the topic, all the part, everything is very comfortably. But for is the immediate and routine care of the baby is a very important part by the mother and everybody is there. Breastfeeding, skin care, care of umbilical care, and care of the, these are the many points which my colleagues are definitely going to cover. And then immunization is the very another part of the today's topic is the, first we should start go for the BC, all the oral poly, everything will be covered by my all colleagues. Neonatal care is a very essential to reduce the morbidity and mortality. Another very important part of today's topic is a nutritional disorder. Deficiency of nutrients in the diet is a very important part in our country because it covers many of the diseases because of this deficiency in the carbohydrate malabsorption, amino acid absorption disorder, fat digestion, protein digestion, growth problem, and one of the most important part is the iron deficiency anemia. Is very which cover the 25% of the disease, and many diseases like the rickets, discovery, very established. These are all are disordered by the nutrition. But my topics of the topic of today will be covered by the expert that like Dr. Anil Kale, Dr. Dattatreya Lodhe sir, Dr. Yogita Srivas, Dr. Vijay Gawai. These are the people, very competent people. What I heard about them, definitely going to cover all the topic very in a large scale and everything will be done. And all the person who have joined so far, definitely going to get benefit of it. But one thing is that want to add one thing that today we are all organizing the webinars and everybody attending. Thus, one thing is all I asked one of the last time I attended once a webinar. I asked one question to the children, all the students who are attending. I asked them which are the best part, whether the webinar is good or the seminar is good. Many of the question could answer, raise their finger, answer. Sir, webinar is good, but seminar is more good because we get chance to eat there, we get a chance to see the around the campus and everything. So I hope that today's webinar is going to be very success because so far about say I can say more than 600 people have connected to this webinar. Then it is going to be successful program of today's webinar. Once again, I thanks to the organizer of this webinar, Dr. Datta Patil, his team, Dr. Asmita, just like she talked to me about, and all the speaker, all the best. And once again, thank you very much for giving me opportunity to speak. All the best for today's seminar. Thank you very much.
Thank you so much, sir. Now I request Dr. Santosh Nevpurkar sir for inaugural speech.
Sir, unmute yourself.
Yeah, I am unmuted.
Yes sir, you are audible.
हाँ, या आज के इस वेबिनार के आयोजक वैद्य दत्ता पाटिल जी, मेरे स्नेही डॉक्टर जुबेर जी, वैद्य अस्मिता जी और इस वेबिनार को संबोधित करने वाले अध्यापक महोदय और आप सभी लोग, बहुत ही इम्पोर्टेंट टॉपिक आज इस वेबिनार के लिए लिया गया है। मैं प्रैक्टिशनर हूं, मैं एकेडमिशियन तो नहीं हूं। मेरे चिकित्सा में या क्लिनिक में जब रुग्ण मेरे पास आते हैं तो समझो मेरे पास अगर 100 रुग्ण आते हैं उसमें से 10 रुग्ण यह बाल रोग के होते हैं, और जो 10 रुग्ण बाल रोग के होते हैं उसमें से 6 रुग्ण जो है वो हमारे आयुर्वेद में कहा गया है कि बाल रोग में क्षीराद, क्षीरान्नाद और अन्नाद ऐसे 3 अवस्था होती है। उसमें से 6 रुग्ण जो है वह क्षीराद अवस्था के हैं। हम अगर आयुर्वेद में अष्टांग आयुर्वेद कहते हैं कि हमारा अष्टांग आयुर्वेद है, तो उसमें कौमार्य भृत्य तंत्र यह 5वां अंग आयुर्वेद का दिया है। शल्यशाला के यह सुश्रुताचार्य ने दिया है और बड़ी अच्छी व्याख्या उन्होंने कही है कि जो आज के हमारे टॉपिक के रिलेटेड है। वो कहते हैं कौमार्य भृत्यम नाम कुमार भरण पोषण, ऐसा वो कहते हैं। कुमार का भरण और पोषण। उसके बाद में करते हैं धात्री क्षीर दोष। यह बहुत इंपॉर्टेंट टॉपिक है। हम जब पीडियाट्रिक पेशेंट देखते हैं, बाल रोग के रुग्ण देखते हैं, तो हमको यह जानना बहुत ही आवश्यक है, कम से कम क्षीराद अवस्था में 1 दिन से 6 महीने तक कि हम स्तन्य परीक्षण करते हैं क्या। अगर करते नहीं है तो यहां से करना शुरू आवश्यक है। दूसरा एक मैं आपको कहना चाहूंगा कि आयुर्वेद प्रैक्टिशनर, वो भी स्पेसिफिकली पीडियाट्रिशियन, आपने कभी देखा है क्या? तो हाँ जी हाँ, आप अगर आयुर्वेद का इतिहास ये करेंगे तो सांगली में कुमार औषधालय नाम से वैद्य परांजपे जी यह केवल बाल रोग चिकित्सा का ही ओपीडी चलाते थे, और वो समय था 1960 से आगे का समय था। बहुत ही अच्छी उनकी ओपीडी थी। तो यह आज के समाज की आवश्यकता है कि आयुर्वेदीय बाल रोग चिकित्सक समाज में आए, प्रैक्टिस में आए। मैं इस वेबिनार के माध्यम से आप सभी को शुभेच्छा देता हूं और सभी जो आज के लेक्चरर हैं उनको भी शुभेच्छा देता हूं कि वो अपना विषय अच्छी तरह से आप सभी लोगों को सामने रखें। मुझे आपके सामने प्रस्तुत होने का एक चांस आपने दिया है। मैं दत्ता जी और उनके टीम को मनपूर्वक धन्यवाद देता हूं और आपके इस वेबिनार को शुभेच्छा देता हूं। धन्यवाद।
Thank you so much, sir. Now I request Dr. Dattatreya Patil sir for presidential address.
National webinar on neonatal care and nutritional disorders in children। इस वेबिनार के उद्घाटन समारोह के प्रमुख अतिथि हमारे ज्येष्ठ मार्गदर्शक आयुर्वेद व्यासपीठ के संस्थापक अध्यक्ष वैद्य संतोष जी नेवपुरकर सर, भारतीय चिकित्सा केंद्रीय परिषद के पूर्व उपाध्यक्ष यूनानी, हमारे ज्येष्ठ मार्गदर्शक डॉक्टर जुबेर शेख सर, इस वेबिनार के लिए जुड़े हुए सभी मान्यवर, हमारे महाविद्यालय के सभी सम्मानीय प्राध्यापक, विद्यार्थी एवं अन्य भारतवर्ष से जुड़े हुए सभी पार्टिसिपेंट्स, वस्तुतः यह जो सेमिनार या वेबिनार हम जिसे कहेंगे, इसके लिए जो टॉपिक चुना गया, नियोनेटल केयर एंड न्यूट्रिशनल डिसऑर्डर्स, आज की परिप्रेक्ष्य में अगर देखा जाए, निश्चित तौर पे भारत में विश्व के अन्य राष्ट्रों की तुलना में नियोनेटल केयर से जो मॉर्टेलिटी हो रही है, वह एक गंभीर समस्या निश्चित तौर पे हमारे हेल्थ सिस्टम के सामने है। और दूसरी बात, भारत जिस विविध पद्धति से न्यूट्रिशनल डिसऑर्डर्स को दूर करने के लिए काम कर रहा है, उसमें भी आयुर्वेद में बताए गए विविध सिद्धांत निश्चित तौर पे अगर सबके सामने आ जाए तो यह अपने आप में एक बहुत बड़ी उपलब्धि होने वाली है। इसीलिए हमारे कौमार भृत्य डिपार्टमेंट के जो फैकल्टी मेंबर्स हैं, डॉक्टर मिस्त्री सर, डॉक्टर भद्रे मैडम, इन्होंने जो टॉपिक चुना, उसके लिए जो हमारे स्पीकर हैं डॉक्टर अनिल काळे जी, जिनका इस टॉपिक पे बहुत अच्छा अध्ययन और अनुभव भी है, और दूसरे जो वक्ता हैं डॉक्टर योगिता श्रीवास जी, वो भी न्यूट्रिशनल डिसऑर्डर्स पे बहुत अच्छा काम इन्होंने गत वर्ष में किया है, और जो हमारे चेयरपर्सन हैं वो भी इस पे अच्छा कमेंट या एक्सपर्टाइज ओपिनियन देने वाले हैं। मैं चाहूंगा आप सभी को कि एक अच्छी वेबिनार का लाभ आप उठाने वाले हैं। मैं इस वेबिनार के माध्यम से आप सभी जो हमारे इनॉग्रल गेस्ट हैं, हमारी संस्था की तरफ से, हमारे महाविद्यालय की तरफ से और व्यक्तिगत तौर पे मैं आप सभी का निश्चित तौर पे स्वागत करता हूं, धन्यवाद देता हूं। आज हम वैद्य प्रता जोशी सर, जिनको हम श्रद्धांजलि अर्पित की, उन्होंने आयुर्वेद शास्त्र के लिए अपना जीवन व्यतीत किया, उनको अंजलि अर्पित करता हूं और अपनी वाणी को विराम देता हूं। जय हिंद, जय महाराष्ट्र।
Thank you, sir, for presidential address. Now, I welcome the expert speakers of this webinar, Dr. Anil Kale, sir, HOD and Professor of Kamarvritya Department, Government Ayurved College, Usmanabad, and Dr. Yogita Shrivas, ma'am, HOD and Professor of Kamarvritya Department, Datta Meghe Ayurved Mahavidyalay, Nagpur. I also welcome our chairpersons of this webinar, Dr. Dattatreya Lode, sir, HOD and Associate Professor of Kamarvritya Department, GS Pune Ayurved College, Ahmednagar, and Honorable Dr. Vijay Kumar Gavai, sir, HOD and Professor of Kamarvritya Department, Government Ayurved College, Nanded. So let's start the first session of this webinar. We have Dr. Dattatreya Lode, sir, as a chairperson for the first session of the webinar. He is HOD and Associate Professor of Kamarvritya Department, GS Pune Ayurved College, Ahmednagar. Sir has completed BMS from Sri Ayurved College, Nagpur in 2003 and MD from Government Ayurved College, Nanded in 2006. He has teaching experience of 15 years and currently member of Board of Studies, MUHS, Nashik. So first session will be delivered by Dr. Anil Kale, sir, on the topic of neonatal care. Sir is HOD and Professor of Kamarvritya Department, Government Ayurved College, Usmanabad. Sir has published more than 15 national and international publications. He has wide range of clinical as well as academic experience. Sir has guided multiple research works to various PG and PhD scholars in all different areas of Kamarvritya. He has 22 years of teaching experience and participated in syllabus reforms committee by CCIM and MUHS for Kamarvritya UG and PG. Sir worked as member of Board of Studies, MUHS, Nashik, and has experience as in charge neonatal care in Sane Guruji Hospital, Pune for 12 years. I request Dr. Anil Kale, sir, to start the first session.
Hello. Hello, Dr. Asmita, I am audible?
Yes, sir, you are audible.
Okay. Fine. Thank you, Dr. Asmita, for your kind words. I also thank our chief guests, Dr. Zubair Sheikh sir and Dr. Santosh Nevapurkar sir, for their blessings for this seminar webinar. Good morning to all the delegates, students, and organizing team of National Webinar on Neonatal Care and Nutritional Disorders in Children. I thank Dr. Datta Patil sir, Principal, Dhanvantari Ayurved Mahavidyalaya, Udgir, faculties of Kumarbhutta Department of Dhanvantari Ayurved Mahavidyalaya, Dr. Mistry, and Dr. Asmita, for giving me this opportunity to share my presentation with you. Actually, the topic neonatal care is a very vast topic, and to cover complete topic in just one session will be injustice to the topic itself. So what I'll do is, as I've been told that most of the participants are undergraduate students, so I'll be concentrating more on the essential newborn care, which we'll be dealing in the next 45 minutes. I also welcome Dr. Dattatreya Lode sir for chairing this session. So I'll begin with my presentation.
Hello, sir. Please, can you share the screen now?
Yeah.
Hello.
Hello, Dr. Asmita. Hello.
Yes, sir. It is visible, sir.
It's visible and I'm audible too, right?
Yes, sir. Yes, sir. Please proceed.
So, as both of our chief guests said, that the both topics, newborn care and malnutrition, have a very major role in defining the child status, health status in our country. I'll be dealing with essential newborn care now. We'll have to go through some basic definitions, though you all must be knowing about this. First is neonatal period. We should know what neonatal period is. From birth up to 28 days period is called as a neonatal period, of which first 7 days, that's first week, is the early neonatal period, and the second, third, and fourth week is called as a late neonatal period. As spoken by our honorable guest, the mortality, child mortality in India is a concerning issue. 2/3 of under 5-year deaths, that is 60% of under 5-year deaths, happen in first year of life. 2/3 of infant deaths, that's deaths occurring in 1 year, first year, are 66% of which are happening in first month. Means 2/3 of infant deaths happen in first month of life. That's in the neonatal period. Whereas 3/4 of the neonatal deaths, is almost 75%, happen on very first day of life. And the basic and main causes of these is prematurity, birth asphyxia, infections, hypothermia, feeding issues. Nearly 20% of all child deaths happen in India. That India is leading in this. The health system has divided the newborn care in different levels. Three basic levels for newborn care are designated. First is newborn care corner, newborn stabilization unit, and special newborn care units. Newborn care corner is must for all birthing facilities. All the hospitals where birth is taking place, this newborn care corner is must. This provides routine care at birth with resuscitation and also identify and refer at-risk and sick babies. Whereas the second level, that is newborn stabilization units, cater all the care of NBCC, that is newborn care corner. In addition to that, it also takes care of sick newborn babies under 1800 grams. Next level is special newborn care units, which again caters both the cares of NBCC and NBSU. In addition to that, it also take care of the below 1800 gram babies and even requiring ventilation. So the care of newborn babies is required immediately at birth. So the care is required immediately at birth. Care is again required in initial few hours of birth and even beyond few hours of birth. We can divide the care in these three aspects. So coming to the essential newborn care, that is the care provided right at birth. The objective of this essential newborn care is to assist in adaptation to the extra-uterine environment and minimize mortality and morbidity. We all know that the transition from intrauterine to extra-uterine life for a baby is a big deal. Baby comes from a very, very secure atmosphere in the womb and is subjected to the exposure of this world. The optimum care given in this is very important for minimizing the mortality and morbidity associated in this. This essential newborn care involves initiation of respiration and oxygenation of blood. So we should initiate the respiration in this baby. Second component is maintenance of body temperature. This is again very crucial. And the third one is feeding establishment, initiation and establishment of breastfeeding at the earliest. It also involves infection prevention measures and also the early detection and management of congenital disorders, other disorders, and infections of newborn. So these actions are achieved through one, immediate care. Also, we need to have a neonatal examination, and thirdly, identify high-risk babies and their management, and if required, even referral of these babies. So the immediate care of birth has these components. First is clearing the airway, APGAR score, evaluation of the baby immediately after birth. Third is temperature maintenance, care of cord, care of eyes and skin, and lastly breastfeeding, initiation and early establishment. So what care or protection does a baby need at birth? Baby is not asking for much. We have to give care of breathing, which protects the baby from hypoxemia. We need to care for the temperature, which protects from hypothermia. We need to care for the feeding of the baby, which protects the baby from hypoglycemia. The care of skin, cord, and eye protects the baby from infection and sepsis. Birth is a very important event of our life. We should start preparing for the birth even before the delivery. We have to be ready with all the equipments, with all equipment required for resuscitation. And so the essential newborn care, each delivery should be considered as an emergency. We never know which baby is going to cry and which baby is not going to cry. Basic readiness is very much necessary and should be ensured. First is assessing the perinatal risk factors. We require at least one person capable of undertaking full resuscitation. If the risk factors are there, 2 persons would be handy. All resuscitation equipment should be ready and in working order. It should be really in working order. In many of the centers, even now we have to run when baby doesn't cry. Also the good teamwork and good communication is a must. Luckily, 90% of the birth transition from intrauterine to extrauterine is very smooth. Around 10% babies require some assistance, and 1 to 2% need extensive resuscitation. Good care improves survival and lays foundation for the optimal physical and neuromotive development in the future. So for the prevention of infection, clean hands, clean perineum, clean delivery surfaces, cleanliness of cord, clamping, cutting, cord care, eye care, hand hygiene before and after handling the babies is quite important. So now we'll see the first component that is the most important of all, that is the clearing the airway. Establishment and maintenance of breathing is the most important objective. Everything else becomes secondary to this clearing of airway. For this positioning, baby is placed on back, warm and hard surface. Neck is slightly extended. We need to wipe the secretions from mouth and nose. If required, gentle suction by suction bulb or catheter can be done. The size should be around 12 to 14 bar. Pressure should not be more than 80 to 100 mm of Hg. We should do the suction of mouth before the nose to prevent aspiration. As seen in the earlier slide, 90% of the babies cry immediately. We should ensure that the baby is crying or breathing at birth, has a good muscle tone, heart rate is more than 100 beats per minute, and baby's color is pale. What if baby is not crying? We should look for the meconium. If absent, dry the baby with warm cloth. This stimulates and helps in initiation of the breathing, and baby starts crying. If meconium is present, gentle suction for the removal of mucus and meconium, first from the mouth and then from the nose, is required. If baby still doesn't cry, then we cut the cord, place the baby on flat, firm and warm surface, position the baby with neck slightly extended, suction mouth and then nose. You stimulate the baby and reposition. If the baby still does not cry, then we require advanced resuscitation of the baby to prevent the neurological damage and death. Secondly, as soon as the baby is delivered, you should examine the baby. For this, APGAR score is recorded. It is recorded at 1 minute and 5 minutes. In APGAR score, we evaluate respiration, circulatory, and neurological status of the baby. Though the APGAR score is taken at 1 minute, we should not wait for the resuscitation till 1 minute. We should start the resuscitation immediately. APGAR score of more than 7 is considered normal. Thirdly, very important temperature control. See, baby is coming from a womb which has a temperature of more than 36 degrees centigrade. Therefore, we should receive the baby at a warm place. The delivery room should be warm, at least more than 25 centigrade should be ensured. We should put off the ACs and fan. We should place the baby under radiant heat warmer or any heat source, and baby should be dried thoroughly and should be wrapped in another warm clean cloth sheets. Head should be dried properly and covered, as maximum heat loss is from head. 70% of the heat loss is from the head. Baby should be given immediately to the mother, and even kangaroo mother care can be should be promoted. Should try to maintain temperature between 36.5 to 37.5 degrees centigrade. We should not rush for the bath. It can be delayed in preterm and LBW baby. It can be delayed further. You can check the warmth by feeling the baby's feet every 15 minutes. See, hypothermia increases oxygen and glucose consumption, and both hypoxemia and hypoglycemia may result in dire consequences and even death. Care of cord is very important to prevent the baby from infection. Cord is cut, tied and cut when it stops pulsating. And the clamping of the cord can be delayed for 30 seconds to 1 minute for to allow additional blood to flow from placenta towards the baby. This helps in conserving the iron resources in baby in infancy. It should be the cord should be cut at 3 to 4 centimeter away from the abdomen with sterile clamp or with sterile thread. The stump should be kept open, dry, and away from the genitals. Nothing is to be applied on umbilical cord stump. It should be inspected frequently for bleeding and oozing. Generally, stump dries and separates by 5 to 10 minutes. Generally, while applying diapers, the stump goes under the diaper. So you can fold the diapers and keep the stump open so that it dries sooner. Regarding care of skin and eyes, the baby should after birth, the blood, mucus, and meconium should be cleaned from the baby before presenting to the mother. Vernix need not to be removed as it protects the newborn baby. Bathing should soon after birth is not recommended. Mopping or wiping with clean moist cloth should be done. When bath is to be given, it should be quick and in warm room with warm water. In preterm and low birth weight babies, it should be further delayed. Eye care by separate sterile cotton swab. Both eyes should be cleaned by separate sterile cotton swab from inner canthus to outer canthus. The last component is exclusive breastfeeding. The initiation and establishment of breastfeeding in newborn baby after birth is very important. Early contact between mother and newborn enables breastfeeding and helps in better bonding between mother and child. The best practices are no prelactal feed should be given. Colostrum is very important. It's the protein, high protein. It is very proteinaceous and rich in antibodies and many of the vitamins. First feed should be given within first hour of life. Correct position to enable the good attachment is very important, particularly in the mothers having first babies, primary mothers. The feeding should be given on demand, and no water feeding should be given. Counseling with proactive measures for initiating breastfeeding is very important. We should talk to the mother. We should explain the position. We should also explain the importance of breastfeeding. Remember, breast milk is the best fluid made by the God. So it is very important that every baby receives breastfeeding soon after. Apart from this, examination of the baby in the labor room is very important. The main objectives of examination of the baby soon after birth is to ensure whether the baby has achieved transition from intrauterine to extrauterine conditions. Secondly, to detect the life-threatening congenital anomalies and any birth injuries. Also to check for any danger signs in the baby, and also to assess the weight in gestation age. After examination, we have to decide where to keep the baby. We should note birth, date, time. We should assign gender, tie identification band, and take footprints. Give vitamin K before shifting to the labor room. I'd like to share one of my experience regarding these activities. Actually, we generally take all these things very casually. We had a baby, 30 to 34 weeker baby. On the second day, he was kept in an ICU, and parents wanted to shift the baby to some other center. So we discharged the baby, and baby was taken to the other center. Mother was with us only. After 2 days, the father of the baby came back and told that he is not happy with the center and he wants to shift the baby back to us. We permitted him. He came with the baby back to our hospital. We again admitted the baby and started our care. Mother was called for the breastfeeding. Baby was on breastfeeding. As soon as the mother saw the baby, she said, "This is not my baby." So it was really shocking. We all thought, what has happened? So these kind of social emergencies are not medical always, they are sometimes social also. So these kind of social emergencies may come anytime if we take all these things casually. So we called up the doctor, the concerned doctor, and shared this with him. But the response from that side was, no, we have sent the same baby which you have sent from your hospital. So it was again a panic situation. So then we had taken this footprints or footmarks of the baby on the paper. We again, the footmarks, we matched with that, again called the doctor and convinced him that no, this is not the same baby. So that baby was again taken to that hospital, and the baby which we shifted was again taken back in our own center. So these kind of emergencies, social emergencies may arise anytime, so we should not take these things casually. So where to keep the baby? We should keep all healthy term babies weighing more than 800 grams with mother in PMC ward. Baby requiring bag and mask ventilation for 30 to 60 seconds, having mild to moderate distress. Transient tachypnea of newborn should be kept in cared in transitional care or in intermediate care area. And babies requiring prolonged resuscitation, having respiratory distress, hemodynamically unstable, having life-threatening congenital anomalies, meconium aspiration syndrome, and other sick babies with danger signs should be managed in neonatal intensive care unit. The danger signs of newborn babies. These should not be looked casually. The signs like poor sucking and baby not sucking well in the breast is a very major sign. It should be personally seen whether the baby is really not feeding on the breast. Lethargy, hypotonia, fever or hypothermia, respiratory distress, any convulsions, vomiting, bleeding from the umbilical stump or GIT, cyanosis, discharge from umbilical stump or infections, abdominal distensions, jaundice reaching palms and soles, swollen and eyelids with pus discharge is also a danger sign, and multiple pustules on skin should be looked at. Care of the newborn with problems. Low birth weight in preterm babies are at increased risk of hypothermia, hypoglycemia, and poor growth. Main principles while caring them are saying they need breastfeeding, and early detection and management of complications. Babies with any other conditions or danger signs may need an ICU care. Now, once the baby is shifted in the ward, baby should be kept with mother, call it bedding in. should be kept warm. Head, body, feet should be covered. Baby should be wrapped in sheet. You can use cap and socks. Feed the baby on demand. Ensure proper positioning and support for breastfeeding. Confirm that the baby has passed urine and meconium within 48 and 24 hours. We can discharge full-term baby in 3 days and lower babies in 5 days, ensuring the establishment of feeding. Before discharge, we should explain mother about exclusive breastfeeding, regarding danger signs in the newborn. We should educate her about immunization and also guide her regarding the follow-ups. So we can summarize it: the essential newborn care is a comprehensive strategy designed to improve the health of newborns through interventions before conception, during pregnancy, at birth, and even in postnatal period. If you see the principles of resuscitation, that is TABC, temperature is maintained by warmer, by drying the baby, removing the wet linen, covering the baby completely, and even by kangaroo mother care. Airway is managed by a position of the infant, clearing the airway by wiping or suction, and sometimes if required, insertion of endotracheal tube. Breathing is managed by tactile stimulation, nasal oxygen, positive pressure ventilation, and by bag and mask, and circulation by chest stimulation, chest compression, and medication. In Ayurveda, the newborn care is dealt in the under the topic of Jatmatra Balak Paricharya, which is nothing but the care of newborn after birth. It includes Mukha Kanta Vishodhan and Garbhoda Kraman, Ulva Parimarjanam, Shiraska Ghrita Pichu, Balatela Abhyanga, Prana Pratyagamanam, Nabhinal Kartana, Jata Karma Sanskara, and Snan. Interestingly, the principles of resuscitation, that is temperature, airway, breathing, and circulation, are very principally very handled, mentioned very concisely in Jatmatra Paricharya. The temperature by Balatela Abhyanga and Shirastha Ghrita Pichu. Airway, for airway, Mukhakanta Vishodhan is being advocated, and also the Garbhoda Kraman for breathing and circulation, Ulva Parimarjan, Prana Pratyagaman, and Balatela Abhyanga. So these steps stimulates the newborn baby, initiates breathing, improves circulation, prevents hypothermia, and relieves delivery stress. Now, these Jatakarma Sanskara serve the same purpose of Jatakarma Sanskara serve the purpose of examination of the baby and initiation of the feeding. Vakpat has also mentioned the features of the baby who do not cry, or features of asphyxiated baby, as baby has deep unconsciousness, do not cry on stimulation, have unstable dhatus, is hypersensitive to pain stimuli, and has a dying-like appearance. Also, prana pratyagaman, if the baby is having asphyxia, he needs to be resuscitated. And resuscitation in Ayurveda is mentioned under the Ashmano Sangatana, Karnamula, which gives auditory stimulation. Sprinkling of cold and hot water is mentioned, which may give sensory stimulation. Panning with Krishna Kapalika may also again stimulate and stimulate to the baby. These, along with Mukha Kanta Vishodhana, Garbhoda Kraman, and Balatela Abhyanga, by principle serve the same purpose of TABC. Now we move on to the Ayurvedic pediatric. The subject called as Kumar Vritya. Kumara means child up to the 16 years. Importantly, it's from conception to 16 years, as Kashyapa includes intrauterine life also in the age classification. And most importantly, if we see the second part of the Kumar Bhrutya, that is Bhritya. It is Bhritya means care, to look after, to help in upbringing of a normal child and management of ill children also. Kashyapa very rightly quotes that life begins at conception and birth of the baby is considered the most important event of the life. If you see the Vyakhya of Kumar Bhritya or definition of Kumar Bhritya, it states that Kumar Bhrityanam Kumara Bharanam Dhatri Kshir Dosha Sanshadanatam Dushkastanya Graha Samuthanam Cha Vyadhinam Upishmanartam. As told by our guest, the main area of, if you see the definition, most of the definition covers the normal baby or the disorders which are related with Bharan Poshan, Dhatri Kshir, Dushkastanya, and Graha Dushti. So Bharan Poshan we can consider it as a feeding issues, malnutrition, and conditions related with growth and development. Dhatri Kshira Dushkastanya, it's related with breastfeeding, weaning, timely weaning. We have mentioned for the Prashan Sanskar and Annaprashan Sanskar, and also the faulty feeding. And lastly, the Graha Dushti. These may be considered as an infection. We need to protect the baby from all these things. See, managing children is always been a challenge. In this world of three, three people have always been set to perform difficult acts. Loke asmistrayo dushakarakariam vishak dhatri cha balascha. So Vaidya, mother and child, they are always involved in the performing difficult acts. And here in this case, all the three, Vaidya, mother and child, they all together are involved. So it is really a dushkaram. Moreover, the challenges in children are baby Sukumar. Sukumar baby is alphabal, having low strength and immunity, has aparipakva dhatu, is immature, is paratantra, have avyakta lakshanas, manifestations of the diseases or conditions are not well expressed. Avachasam is unable to speak and convey his pain. Baby is again very much involved in the rapid growth and development. The baby we see today is different from the baby we see in a couple of days. We talk in neonatal settings, we talk in the terms of day 1, day of life, day 1, day 2, day 3. Also, the cooperation in examination in the baby is not always warranted. Diseases, presentation, response to the treatment is different than pediatric age group. There are limitation and intolerance to many medication and also to some procedures which are, that are not indicated in children, and also has a very high mortality. So, seeing the health status of our country, particularly of children, I find there is a need of alternative medicine in public health sector, which might be because of emergence of new organisms, growing resistance to antibiotics. Providing existing healthcare is difficult in a huge country like India. There is an easy acceptability, availability, and cost effectiveness to the cultural, traditional practices prevalent in population. We need to increase the participation in child-related health programs. For this, we need to identify potential areas of Ayurveda in child health care, maybe preventive, promotive, and even curative. So what we have, in Ayurveda in newborn care, we hardly have anything. We can give Swarna Prashana, which is said to increase the immunity, works as an immunity booster. improves intellect, and is a health promoter. We can include Abhyanga in this, as we have seen, prevents from hypothermia and also has a nutritional value. Can promote breastfeeding. There are some drugs given like Balbutis and medication for GI disturbances, some health promoters, immunity boosters, and many drugs are prescribed in neonates. This supragenal concept is very upcoming, and at least in Maharashtra, it's becoming very popular. We should give a thought on this also, and we should look for the preventive and health promotive practices. Regarding supragenal, as we said, that the motive of essential newborn care is the improvement in the baby, right from the conception to the postnatal ward. So in supragenal, we expect for better progeny, so the birth should be planned actually. We should prepare the body before the conception. Both mother and father should be should go through the body cleansing processes, that is panchkarma and some medication, which may result in beach shuddhis in both of them, and which may result into the reducing the adipal pravarti vyadhi, that's more of a hereditary disorders. Whereas Garbhani Paricharya, the Garbhani part is already taken into the pediatrics itself by our acharyas. Planned monthly regimen with herbal medication along with some code of conduct may reduce chances of congenital disorders, premature birth, other complications, general probabilities, and these are popularly practiced as Garbha Sanskara for healthy and better position. This is also followed in present management also. Before conception, adequate care of girl child is required, which is by nutrition, proper education, and healthcare. Immunization, including TT, folate supplementation, birth spacing, prevention of sexually transmitted diseases, avoidance of drugs and substance abuse before conception are very helpful. In antenatal period, at least 4 antenatal visits should be done. Tetanus injection should be given to the pregnant lady. Iron and folic acid supplementation should be done. Adequate nutrition, intake of iodized salt should be assured. Mother should take, the pregnant lady should take adequate rest, should be prepared for the delivery, and timely identification of the problems in mother and its treatment are important. Regarding newborn practices, there are many of the traditional and cultural health practices prevalent in our country. Root of these, many of these healthcare practices are embedded in our traditional and cultural practices. These practices related with newborn care are like baby massage, oil drops in ear, applying mud, sindoor on umbilical stump, burn marks on abdomen, tying thread around waist, arm, neck, applying tika, kajal on cheeks, etc. So these are the traditional or cultural practices related with newborn care, which are practiced in particularly rural areas. If you see, some of these practices are useful, some of them are harmless, and some of them are harmful. So useful practices among them needs to be identified and needs to be validated through clinical trials and should be promoted and practiced. So we should identify the useful practices amongst them. We should study and identify the useful practices, and we should promote them. Harmless practices we should stop and discourage. We should not promote them. We should stop them right away. And regarding harmless practices, we can allow them and continue also, like tying thread in waist or wrist, or these kind, or tika on cheeks and forehead. There's no harm in this. So these are related with the faith of the faith and customs of the family. So they can be allowed to be continued. So useful, to promote them; harmless, allow and continue; and harmful should be strictly stopped and discouraged. Lastly, believing in Ayurveda is different from understanding Ayurveda. These practices or the management we do needs validation and should be reproducible. So after validation and reproducibility, that is faith with rationality, these practices can be employed in the newborn care. With this, I conclude my presentation and thank the organizers. Thank you.
Thank you, sir, for your clinical and informative presentation, which definitely helps us while attending birth call as a pediatrician as well as for normal newborn care. Moving towards question answer session, we have some questions regarding the neonatal care. I request Dr. Anil Kale sir to elaborate these questions. First one is, what are the current figures of neonatal and infant mortality rates?
Okay. The mortality rate of neonates and infants is on the improving side in the last decade. Present neonatal mortality rate is 26, and infant mortality rate is 39. So this has been the improvement has been seen in this, but lot more has to be done. Thank you. Any other question?
Yes. What are the main causes of high mortality?
Hello.
Yes, sir.
Any other question?
What are the main causes of high mortality?
In newborn care or in neonates?
Newborn care, sir.
Okay. As I shared in the slides, the common important causes of increased mortality in newborn care is birth asphyxia, prematurity, hypothermia, neonatal infections, and feeding issues. And the reason for these are we can say most of the deliveries still are occurring in home setups. So home delivered baby tend to have more of these problems. Secondly, the identification of risk factors in these babies is lacking, particularly in the home delivered baby, or is delayed, and the referral to the appropriate center, and there is a delay in the referral to the appropriate center is also one of the reasons of the increased mortality in these cases. But now, currently, government has appointed ASHA workers for home-based neonatal care. So these ASHA workers visit home and ensure frequently, rather they visit for 6 to 7 times and frequently see the status of the baby and inform the health centers. So this has definitely helped in reducing the neonatal mortality in India. And one more important reason might be the unhealthy or unhygienic care during birth.
Okay, sir. The next question is breastfeeding contraindicated in COVID positive mother?
Can you repeat the question?
Is breastfeeding is contraindicated in COVID positive mother?
Okay. Coincidentally, our center, Osmanabad Hospital, has been designated for all suspected and COVID positive deliveries. So we have dealt with some neonates who have newborns born with COVID positive or suspected mothers. So in this, what we say is the benefit of breastfeeding overweights the risk of transmission of COVID from mother. So if mother is not able to take care of the baby herself, means mother is COVID positive and is ill, the baby can be cared by a non-positive parent or relative of the mother. And mother can give express breast milk with proper care. And we generally take the consent of mother, whether mother is ready to feed the baby, explaining the all possible risks to the mother. If mother gives the consent of express breastfeeding, we give express breastfeeding, and if mother says that she wants to feed the baby on breast with consent and with protection, with hand hygiene, with good mask, we allow the mother to feed the baby. So it's not a direct contraindication. So there are incidences, there are reported incidences where the infection is transmitted even vertically and even horizontally from mother. But I have not heard of many babies and babies having severe illness or even after turning COVID positive. So it's not a straight way, it's not a contraindication of breastfeeding.
Okay, sir. Next question is, any methodology or clues for the newborn and infants examination in Ayurveda?
Okay, examination of newborn in Ayurveda, right? Okay, so soon after birth there is a mention of Jat Karma Sanskara. Okay, so that is the first opportunity to really examine the baby. We can examine the baby plus oral cavity for any congenital anomaly. Also, the Jatakarma Sanskara includes initiation of the breastfeeding also. So you can put the baby on breast and see whether the baby is ready for the breastfeeding. In the way you can also guess the gestation age of the breast. So this is the first instance where a newborn examination can be done. Secondly, the signs of healthy baby and asphyxiated baby, as it shared in the slide, also has been mentioned by Barbeta. Healthy baby is a baby who is growing well, who is passing urine and stool, who is feeding well, is considered as a growing baby, healthy baby, and the baby who does not respond is like the signs of asphyxiated, as I mentioned earlier. That are also clues for the danger signs of the newborn. Thirdly, in Lakshana Adhyaya, examination of the baby from head to toe is mentioned, so that can be implemented here. Moreover, in Lakshana Adhyaya itself, Kashyapa has said that baby can be examined with a very nice quotation. Yatha vaktam tatha vrattam, yatha chakshu tatha mana, yatha chakshu tatha mana, yatha vaktam tatha vrattam, yatha rupa tatha guna, and yatha swaro tatha sara. So by examining this, we can assess the condition of the baby. And for ill babies, some clues or diagnostic clues are given in Vedana Adhyaya also. I think this is enough for me.
Okay, sir. One last question for
Hello.
some participants. Do you support use of Balguti?
Balguti.
Yes, sir.
See, I mentioned that these practices, some of these practices are useful, some are harmful, and some are harmless. So I consider that many of our practices are useful if they are validated and clinically proved. So the practicing the practice of giving Balguti is I definitely support it. Uh, uh, Having said that, the Guti should be given in a sterile and bottle with a sterile dropper. So it should not be, handling should not be uh, the source of infection in this.
Thank you so much, sir, for your clinical and informative presentation, which definitely help us in our clinical practice. Now,
Thank you, ma'am.
I request Honorable Dr. Dattatreya Lode, sir, to give concluding remarks on this session.
Hello. Hello.
Yes, sir, you are audible.
Okay, thank you. Thank you, organizers, to given me an opportunity to chairperson this presentation on online webinar. And Dr. Kade sir, eminent pediatrician from Government Ayurved College, Osmanabad, and all faculties in Ayurved Pediatrics in Maharashtra knows to him, and the perfectness and skill of the handling of pediatric patients. So there was a nice presentation by respected Kade sir, and the topic was very vast as neonatal care, but he covered all basic aspects of classification of newborn and management accordingly. So what is the classification? First we have to know, and then whether it is a full term, whether it is a preterm, or whether it is a post dated newborn. So management varies accordingly. So it was good informative and knowledgeable presentation. He also included management of newborn according to the Ayurvedic classics. Also, he included social factors or social impacts while we are dealing with the management of newborn. So I congratulate our respectable Kade sir, Dr. Kade sir, who is an eminent pediatrician, to present a good, nice, informative presentation here. Thank you all.
Thank you, sir. Let's start the second session. We have Honorable Dr. Vijay Kumar Gavai, sir, as a chairperson for the second session of the webinar. Sir is HOD and Professor of Comorbidity Department, Government Ayurved College, Nanded, and sir has completed BMS, MD, and PhD from the same college, Government Ayurved College, Nanded. He has wide range of clinical as well as academic experience. Sir has guided multiple research work to more than 17 PG and PhD scholars in all different areas of comorbidity. He has 23 years of teaching experience. Sir worked as Board of Studies member and member of LIC at MHS Nashik. He worked as examiner for UG and PG at MHS Nashik, SRTMU Nanded, and KLE University Belgaum. So, second session will be delivered by Dr. Yogita Srivas ma'am on the topic nutritional disorders of children. Ma'am has completed BMS from Sri Ayurved College, Nagpur in 1998 and MD from same college, Sri Ayurved College, Nagpur in 2003. She has 17-year teaching experience and currently pursuing a PhD, and authored a book Panchakarma in Pediatrics approved by CCIM. Ma'am has published a number of national and international publications. I request Dr. Yogita Srivas ma'am to start the second session.
Very good morning to my seniors present here and all. First of all, I thank the organizing team, Dr. Datta Patil sir, Dr. Mistry madam, Dr. Bhadre, for providing me an opportunity to present my views on the topic nutritional disorders in children. With due respect to all the seniors present here, I shall start my presentation. Dr. Asmita, can you please share the screen? Dr. Asmita?
Yes, ma'am, just a minute. Just a minute, ma'am, I will share the screen. Yes, ma'am, you can continue.
Today's topic is a bit vast to cover in 1 hour, but I have tried to make it as simple as possible and as fast as we can go through. Next. The learning objectives of today's presentation is we have to know about the nutritional disorders commonly found in children. Next. Specific learning objectives can be summarized as to understand the causes, manifestation, and treatment of commonly occurring nutritional disorders in children, and to understand the preventive aspect of malnutrition in a developing country like us. Next. The topic deals with nutrition. So first we have to understand what is nutrition. Nutrition means it is a process. It is not just ingesting the food. It is a process after ingestion of food, which includes digestion, absorption, assimilation, its utilization for body functions, and excretion of non-useful things. So the act or process of nourishing or being nourished is called as nutrition. While talking about nutrition in Ayurveda, we come to Ahar and Ahar Ras Nirmiti. The process of taking good quality Ahar and the process of formation of quality Rasa Dhatu, Ahar Ras, and followed by formation of quality Dhatus. It involves different aspects like exception, digestion, distribution, according to various nyayas told in Ayurveda. May it be Kedari Kulla, may it be Kshiradadhi, and others. But the gist of the matter is, once the food is gone inside, the quality food is gone inside, finally the outcome of good diet is considered as a formation of good tissues and the maintenance of health. This maintenance of health can be related to immunity. Next. Now, we have understood nutrition. So we must also go through what is malnutrition. Malnutrition is the cellular imbalance between supply and the demand. Whatever nutrients are required, if they are supplied more than the demand, if the previous slide one, if the demand is less and supply is more, it creates overnutrition. And if the requirement is more and the supply is less, it goes towards undernutrition. This can be related to samadhatu avastha. Excess is also not required and less is also not required. Next. Now, types of malnutrition can be categorized as primary one and secondary one. As we have seen in earlier slide, Primary is related to diet. The diet is inadequate and leading to malnutrition is called as primary one. And if the diet is adequate, but its utilization is not proper due to maybe due to malabsorption, due to disturbances in gut flora or at any other level in a body, it's even if it is absorbed, its utilization and after utilization, its storage, if it is affected, it is called as secondary malnutrition. And excessive loss due to any reason like diarrhea or blood loss, the nutrients are lost, and that leads to malnutrition. And the fourth one is also very important. It is increased nutrients, excessive supply. So this also leads to malnutrition. Next. Now, what is the need to know about malnutrition in children? We all know that children grow very fast, and infancy is the most rapidly growing phase. Most of the growth and development takes place during this phase, and it coincides with the maximum brain growth occurring up to 2 years of age. For this maximum brain growth and body growth, maximum energy is required than any other period of growth. There are growth spurts in pediatric age group. Even as compared to puberty, more energy is required during infancy. Brain growth is happening. That's why neurocognitive development is also related to nutrition during this phase. And most importantly, nutrition in initial 1 to 3 years predict adult stature and health outcomes. Means this phase is the foundation of healthy adulthood. So we have to be careful about malnutrition during this stage only. Next. What happens in adults? Energy is required for 3 things: to maintain body weight, for digestion and absorption of food, and last, physical activity. But children need extra energy because something extra is happening in their body, and that is tissue growth. Proliferation of cells and increase in tissue is something extra which is taking place during child growth. So children require more energy than adults. The estimated energy requirement of children is as good as double than that of adults. Next. Now, what can be the consequences of nutritional deficiency? Nutritional deficiency, first of all, leads to limited growth. As we have seen, mostly the energy is utilized and required during childhood for tissue growth. So if there is lack of energy or reduced energy, it's obviously going to affect the growth. And the optimum growth which is expected does not happen in children. Second is impaired immune function. This factor is very important. This effect is very important, as malnutrition, it may be overnutrition or may be undernutrition. Both the conditions affect immune function adversely. If overnutrition is there, it leads to non-communicable diseases, and if undernutrition is there, it is responsible for communicable diseases. So immune system, what happens, there is a double burden of over and undernutrition during childhood. Overnutrition and undernutrition makes changes in immune epigenome, and these changes result in chronic inflammatory reaction by the immune system and hyper stimulation of immune system. So immunity gets imbalanced, and this imbalanced immunity, already children have immature immune systems, and this disturbed immunity leads to infections, and infections leads to altered gut microbiota. So these changes are adversely affecting the immature immune function of children. Now, next aspect is neurodevelopment. As we know that most of the brain growth happens during first 2 years of life, and then remaining up to 5 years of life, and a very little portion of 12 years. So this nutritional deficiency affects the maturation of neurons and myelination of neurons. So the end result is neurodevelopment gets disturbed. Now, one more aspect is increased morbidity and mortality. Increased mortality and morbidity we can correlate to infant मृत्यु दर हम जो बोलते हैं, and under 5 mortality rate, as mentioned by Kaya sir, is an index for measuring general health condition of a country. And under 5 mortality rate has been included in Millennium Development Goals. India was supposed to reduce the under 5 mortality rate from 35 to 29 by 2015. But we could not achieve the target. And under 5 mortality is a very huge impact of nutritional deficiency. So more the under 5 mortality rate, more we will be lagging behind in health scenario. Next. Now what happens whenever there is malnutrition, maybe over or under, there is a vicious cycle between infection, impaired immunity, and malabsorption or malnutrition. Whenever there is malnutrition, immunity is affected, as I have told in the earlier slide. And impaired immunity makes the child prone to infections. And once the child gets infected, it is going to affect the gut microbiota, it is going to affect the absorption of nutrients, it is going to affect nutrition. So this is a vicious cycle interrelated with each other. Next. Now we come to nutrients. That nutrients can be divided in 2 types, macro and micro. Macronutrients include carbohydrates, proteins, and fats, and micronutrients include vitamins, minerals, and many other elements like sodium, magnesium, phosphate, etc. Next. So macronutrient deficiency results in PEM, protein energy malnutrition, which is divided in 3 types: marasmus, marasmic kwashiorkor, and kwashiorkor. PEM is common. Protein and energy malnutrition is common in marasmus as well as kwashiorkor. Only the difference is marasmus and kwashiorkor are dominated by more of carbohydrate deficiency, and kwashiorkor as more of protein deficiency. And a micronutrients deficiency results in vitamin deficiencies like water-soluble vitamins and fat-soluble vitamins. In mineral deficiencies, iron, iodine, zinc, calcium, electrolytes, and others. So these are the two main categories of nutrient deficiencies. Next. Now, how to know that child is having PM? So this can be done with the help of anthropometry. Anthropometry is the science that deals with body parts measurement. And commonly used indices are weight for age, height for age, weight for height, mid upper arm circumference. And most commonly used is a weight for age, because in OPD settings, it is easier to check the weight immediately and note it down. And height is a little bit, not very difficult, a little bit lengthy process than measuring weight. Second is mid upper arm circumference is also used for screening when we are screening a large number of patients, large number of in a big setting. Next is body mass index and skin fold thickness. So these are the anthropometrical measurements which can be used to determine protein energy malnutrition. Next. Commonly used terms in PEM are stunting and muscle wasting. A normal child is having normal weight and normal height. But a muscle wasting child will have thinner muscle mass than normal. It may appear thinner than the normal children. And stunting means the height is lesser than normal. And wasted and stunted includes thinner as well as shorter than normal criteria. So these are the terms which we will be referring to in further slides. Next. There are many types of classification for PEM. Indian Academy of Pediatrics classification is very easy to understand, so I have mentioned it here. It measures weight for age. So if the weight is more than 80%, the child is considered as normal. Between 70 to 80%, grade 1 PEM, 61 to 70% grade 2 PEM. And if 51 to 60% weight only is there, then it is grade 3 PEM. And less than 50% weight is there, it is termed as grade 4 PEM. Next. Other classifications are WHO classification, which measures height for age and stunting. It is used for calculating stunting. McLaren classification is also very easy to understand for stunting. It categorizes stunting in malnutrition in acute and chronic. It measures height for age and weight. In acute conditions, height for age is normal and weight is lower. In chronic conditions, height and weight for age are lower. One more classification is there. Wellcome Trust classification it measures weight for age. It clearly, using this classification, we can clearly categorize between Kwashiorkor and marasmus. So weight for age, if it is between 80 to 60% without edema, it is simple underweight. And if the weight is between 80 to 60% with edema, it is labeled as Kwashiorkor. If the weight is less than 60% without edema, it is known as marasmus. And if the weight is less than 60% and with edema, it is classified as marasmic Kwashiorkor. Now, one of the index I'm mentioning here, it is mid-upper arm circumference. It is used for screening children from 6 months to 5 years. The benefit is between 1 to 5 years, it is constant, and so we can rely on it. And it is measured at midpoint of upper arm. The ranges are, if mid-upper arm circumference is more than 13.5 centimeter, it is considered as normal. And if it is between 12.5 to 13.5 centimeter, it is termed as moderate PEM. And if it is less than 12.5 centimeter, it is termed as severe PEM. There are few other tests. This is the tape used for measuring mid-upper arm circumference. There are few other things which can be used to define some anthropometric measurements. One is bangle test. A 4 centimeter diameter bangle is passed through the hands of the child, and if it crosses the elbow, then it is considered that mid-upper arm circumference is less than 12.5 centimeter, and the child is having malnutrition. One more method is quack stick test. Quack stick test, it is a rod. It is a rod measuring, giving two types of markings. It is a height, and one is height and other is mid-upper arm circumference for height. If the height is found more, if height is measured more in this stick, then then mid-upper arm circumference, then the child is supposed to be malnourished. Similarly, BMI is also an indicator of malnutrition. Next. So BMI can be measured as weight upon height in meters square, weight in kgs. There are no fixed standards for BMI in children. Like in adults, there is a particular range. This is normal and this is not. So other classifications are also more reliable. Next is skin fold thickness. Skin fold thickness is used to estimate muscle wasting. It is measured with Herpinden's caliper over triceps, or generally on triceps on mid left arm, hanging loosely by the side. Actually, there are 9 sides which can be used for measuring skin fold thickness. These are chest or pectoral region, mid axillary region, suprailiac or flanks. It can be measured on abdominal wall also. It can be measured in mid thigh, quadriceps muscles. It can be measured on triceps. It can be measured on biceps and subscapular region, inferior angle of scapula. Next, these are the calipers used. This is a metal caliper. There are many plastic calipers are also available nowadays. Next, in the lower picture, previous one, in the lower picture, you can see thickness is measured in thigh region and triceps region. Next, now coming to 2 main categories of PEM. These are marasmus and kwashiorkor. Marasmus and kwashiorkor are 2 types which can be easily differentiated according to clinical features. Marasmus has more deficiency of energy, and there is gradual loss of subcutaneous fat from the body. As carbohydrates provides energy to the body, a carbohydrate lack results in energy deficient state, and that's why body takes energy from the subcutaneous fat in the body. So there is gradual loss of fat in the body, and it can be graded as grade 1, grade 2, grade 3, grade 4 according to its disappearance, of the fat from the body. The child with marasmus typically appears with a large head with sunken anterior fontanelle, and the face appears like an old man. So it is called old man's face due to loss of fat. There are wrinkles, eyes are sunken, wrinkled skin is there. Therefore, in buttock region also, there are muscle folds hanging loosely. Muscles are hypotonic, extremities may be cold, skin is dry, child is irritable, and appetite is voracious. There are delay in developmental motor milestones, and stunting is predominant. Height is more affected. There is loss of weight also, but height is more affected. And it occurs in less than 1 year child. So this is the picture of marasmus. Next. Now, kwashiorkor is a later stage. It generally seen in 1 to 3 years of age. In this condition, there is edema. So face appears round or moon-like. So it is called moon faces. Child is apathetic. Child is dull, non-reacting. It is not interested in what is happening in the surrounding. Not interested in toys given to him. And there is less spontaneous activity. He is less reactive. So there are, even if we stimulate, he will not be reacting. He will not be giving response immediately. The cry is weak. Edema, muscle wasting is very much is there, but it is covered due to edema. Due to edema, muscle wasting is not apparently visible. There are skin changes, dry and scaly skin, and flaky pain dermatosis is a term which is seen in flexor aspects, and on the extensor aspects there is hyperpigmentation. The layers of paint as are removable from the wall. In the same way, the skin is shaded and flakes fall. So it is called as flaky paint dermatosis. In the hair, we find a sign that is flag sign. Flag sign is pigmentation bands. Lighter the pigmentation of hair, it corresponds to lesser nutrition. And if nutrition is made available, the hair growth during that phase may get a little darker pigmentation. So there are bands visible in the hair, and it is called as flag sign. There are commonly seen superficial skin infections like scabies, pyoderma, and fungal infections, candidiasis. And typical feature is muscle tone is lost, therefore abdomen is distended. So appearance is like pot belly. And signs of associated vitamin deficiencies are there. Next. Next. The picture describes the difference between a child of Kwashiorkor and a child of marasmus. So as you can see, a Kwashiorkor child may appear to be healthy, but the prognosis is more worse in Kwashiorkor. And the marasmic child is very, what we call as shushka, mass shushkata is more visible. Next. Actually, there are stages according to management. Mild to moderate cases of PEM can be, if they're clinically well, they can be managed in OPD settings. But in severe cases of malnutrition, there are 10 steps for management. This is the first step is we have to hospitalize the severely malnourished child. And next step is these are 10 steps written here: prevention of hypoglycemia, then hypothermia, dehydration, IV fluid supplementation, then balancing electrolytes, then treating infections, micronutrient supplementation, and gradually, when the child is stable, the pediatrician shifts the child to cautious feeding. There is gradual feeding. F75 formula or F100 formula is used. And feeding should be very gradual, because if immediate and very fast feeding is provided to the child, one syndrome is there. It is called recovery syndrome, and it is not good for the child. So gradually we have to rebuild the vascular tissue, and we have to acquire the catch-up growth. And we have to provide the love and care, and we have to take the patient's follow-up very honestly. While considering management of, while considering PEM in Ayurveda, one more thing I forgot to mention: WHO do not recommend formula supplementary feeds in mild and moderate PEM cases. So mild and moderate PEM cases should be managed with routine nutrient supplementation and dietary advice and dietary changes. Now in Ayurveda, when we consider Kuposhan Janya Vyadhi, we come across two terms, Parigarbhic and Fakka. The etiology of Parigarbhic and Fakka is similar in some aspects. Both results due to early weaning. But Parigarbhic can be considered as an early stage in which physical activity is not hampered, and Fakka can be considered as a later stage where physical activity is hampered and prognosis is more poor. While considering the treatment of Kuposhan Janya Vyadhi, for Parigarbhic, it is prescribed that we have to do Agnidipan Chikitsa. And for Fakka, there has been advised Ghritpan with Kalyana Ghrit, Shatpal Ghrit, Amrita Ghrit, and then Shodhan with Trivrit Kshir. And then Basti is advised, and a special Raj Tel has been advised for massage. And before, we must not advise the Brohan Chikitsa immediately after diagnosing Kuposhan Janya Vyadhi. We have to think about the Agni, and we have to think about the Grahani, and one more factor, that is constipation. Considering these three factors, we have to decide the line of treatment. For Agni Dipan, any Dipan Pashan Dravya can be used. Even simple use of simple Trikatu or simple Sitobladi Shuruna can work as Agni Dipak. And once the coast is set, coast is clear, then we can go for Brahan Chikitsa with dietary supplements and some medicinal kruta like Sthiradi Krut, Yashtimadu Krut, Shatavari Krut. These can be used. And generally, when we consider Shosh, the reasons are similar to Kapha Vardhak reasons. Ati Divaswap, and excess of cold water intake, and Kapha Dushta Stanyapan. Shosh may occur during breastfeeding or after breastfeeding. So we have to decide, it is a topic of research to decide, like we have a Sansarjan Kram in Panchakarma Chikitsa. We have to should design a Sansarjan Kram for treating PEM patients according to Ayurvedic methods. Generally, giving little bit of Anulomak Dravyas help a lot, and even liver tonics also help in these patients. We see that government is taking a lot of efforts. Government is providing many supplements for malnourished children, making some special policies for removal of malnutrition. But we are not as successful, as though there has been a reduction, but we are not as successful as we expected. So I think it is my personal opinion that we should think of boosting digestive power first, and then give those supplements. And this should be applied practically. Next. We have seen deficiency disorder. Now next is obesity. Obesity is a result of overnutrition. Generally, a child is said to be obese when there is excessive accumulation of fat in body parts. And most reliable index is BMI, because it more correlates with subcutaneous and total body fat. BMI above 85 to 95th percentile can be considered as obesity. Next. The causes of obesity, when we go through, we find that mostly the obesity is caused due to excess calorie intake or due to lack of exercise. Whatever calories a child is taking, it is not being burnt, it is not being utilized, so it gets deposited. And there is one more factor called leptin. Leptin gives a sense of satisfaction after eating. In the deficiency of leptin, the child do not feel that his tummy is full, so he eats more. So deficiency of leptin causes more eating and more caloric intake. We have to differentiate between some simple excess calorie intake and some other causes of obesity. So we can say that children with exogenous cause, taking excess calories, generally have normal height or are tall. They are not short. This is the major difference we can see. And pathological causes are generally uncommon in exogenous obesity. And children with organic causes are generally short. Hypothyroidism may present as modest obesity, but there is reduced appetite. In general obesity, simple normal obesity, there is no loss of appetite. Patient or child wants to eat more, but in hypothyroidism, there is a loss of appetite, reduction in appetite. The Cushing syndromes. Cushing syndrome, we can differentiate from obese child and Cushing syndrome child with the help of his face and some other clinical features. The face of a Cushing child looks immature for age. It does not happen in simple obesity. Drugs like sodium valproate and steroids also cause obesity, and some syndromes like Prader-Willi syndrome and others. There are many syndromes. which cause obesity. Next. The consequences of obesity are insulin resistance. There is a typical pigmentation which is called as acanthosis nigricans. There are elevated triglycerides and very low density lipids which are harmful for the body. There is fat deposition in the liver. There is hypertension. Obesity may lead to PCOD in females. Obesity is a cause of obstructive sleep apnea. And obese child face social taboo because of his poor body image, and mental depression may occur. Next. The investigations which are to be done are blood pressure, fasting, fasting and postprandial BSL, lipid profile, thyroid function test, bone age, and USG to rule out PCOD. So we can go for these investigations so that the cause can be ruled out, whether it is exogenous or some organic cause is there. Management mainly depends on gradual calorie restriction. It is not that suddenly the child is forced to withdraw calories. Suddenly he is allowed to do fasting. We have to start with 10% reduction in child's daily intake. Whatever the quantity the child is eating, we have to reduce it by 10%. And we have to provide the fiber-rich diet. We have to stress more on fruits and fibers. We have to advise exercise for at least 30 minutes a day. Aerobic exercises like jogging, walking, running, skipping can help a lot. Target should be to at least keep the weight steady. If the child is not losing weight, maintenance of steady weight is also a good indicator that your strategy is working. And reduction of weight should be targeted as just 0.5 kg per month. There should be gradual loss of weight. And gross intake of wheat and rice should be reduced. We think that fats are the most major contributing factors, but it is found that wheat and rice contribute more to obesity than fats. Reduced added sugar drinks and juices. Ready sugar supply to the body leads to obesity. So we have to reduce the intake of juices and drinks containing additional sugar. And most importantly, the junk food. Children are eating junk food a lot nowadays, and our eating habits have shifted from Ayurvedic appropriate method ones to wrong Western methods. So that is also a major contributing factor. So junk food has to be avoided. Next. And the diet of an obese child can be reduced, can be categorized like greens, yellows, and reds, like a traffic signal. So green vegetables are always allowed. Wheat and rice, these things are restricted intake, and fats and added sugars can be considered as a red signal. We should not advise them. Next. We have seen macronutrient deficiency like PEM and obesity. Now we are moving to vitamin deficiencies. Vitamin A is a very important vitamin. It is, as you can see in the slide, it is very important for vision and eye health, reproduction, tissue differentiation, and immune function. It is called as anti-infection vitamin also. So deficiency leads to eye changes and some skin changes also. Without spores, photophobia, xerophthalmia, night blindness, corneal ulceration, keratomalacia, prone to infection, means chances of infection increases, and retarded growth. Excess of vitamin A also results in some things which are enlisted here. Next. WHO has given a classification of xerophthalmia these are the stages of vitamin deficiencies, and its consequences are finally it leads to blindness. So preventable blindness is a term where methods to prevent blindness in children are adopted. So vitamin A, if given as a supplement, it can it helps in alleviating preventable blindness. Next, the doses are if the child is below 1 year, 1 lakh international units, 2 doses, 1 month gap. And if the child is above between 1 to 2 years and above, 2 lakh international units. WHO recommend 2 doses of 2 lakh international units for 2 consecutive days and followed by another dose after 2 to 4 weeks. In Indian immunization centers, generally 6 months, at a gap of 6 months, 2 doses have been advised as per the age and dose as per the age. It is helping a lot in reducing infections as well as conserving eye health. Next. Now coming to vitamin D. Vitamin D is a very important vitamin, as during a pandemic also you must have heard vitamin D3, take vitamin D3, it increases immunity, it boosts immunity. So many people took vitamin D3 also. But apart from immunity, vitamin D is also responsible for calcium and phosphorus regulation. It helps in bone mineralization, so helps in bone growth, and it activates immune function at various stages. So there are many things which are acting for immunity boosting at different levels. These are the hot topics of research. Vitamin D also regulates insulin secretion. So insulin secretion, if excess of insulin resistance is there, it leads to obesity. So regulation of insulin is also must, and it helps in regulation of muscle calcium transport. So basically it revolves around calcium and immune system. So it has a very important role to play. Next. Deficiency of vitamin D causes rickets. Rickets is the failure of mineralization of growing bone. And there are two terms, rickets and osteomalacia. Rickets is the failure of mineralization of growing bone, whereas failure of mineralization of mature bone is called as osteomalacia. Here I have included rickets only. For rickets, in addition to vitamin D, calcium and phosphates are also needed. Next. Rickets is seen during infancy, and these are the 10 important clinical features. We are starting from the head to toe. We can see that there is delayed closure of anterior fontanelle. There are wide sutures. There is craniotapes, softening of skull bones. There is frontal bossing, dental hypoplasia. There is rachitic rosary. The costochondrial joints get enlarged, and it is round in shape. Fusion chase is also a feature. Pectus carinatum. Then there is a sulcus. There appears a groove formed below ribs near and abdomen, between abdomen and ribs. It is called as Harrison's sulcus. There is widening of epiphyseal ends of wrist bones and ankle bones. So there is swelling. It appears as swelling in wrist and ankle joints. Bowing of legs is also a typical feature of rickets. Next. The treatment includes vitamin D supplementation, 60,000 units per week for 6 weeks, and X-ray to be done after 1 week. If the healing line is seen, then regular supplementation is given. If the healing line is not seen, the same course, many pediatricians advise the same course to be repeated. And even after the repetition of the same course, again, no response is seen, then refractory rickets can be suspected. Next. I have shortened the topic because a lot more has to be covered. Vitamin B complex, as you see, there are multiple roles of components of vitamin B complex. B1, B2, B3, B5, B6, B12, B7, B9. These apparently produce some clinical manifestations in children. So B1 causes very is now a rare disease. And B1 is responsible for carbohydrate metabolism and neurotransmission. B2 riboflavin deficiency is commonly seen in children. It appears as glossitis, and chelosis, angular stomatitis it is called. There is smoothing of tongue, and oral ulcers are also there. Then there is one more feature which can be correlated to B2 deficiency. It is photophobia. Brightness cannot be tolerated by the child, and growth is affected as it deals with B2 deals with fatty acid and carbohydrate metabolism and cellular respiration. Next is B3 niacin. Pellagra is a disease which includes 3 Ds: dementia, dermatitis, and diarrhea. B3 plays a role in respiration, cell differentiation, and DNA processing. So this is a very important component of vitamin B. And pellagra is seen in adults also. B5 is a generally complaints are irritability, failure to thrive, and convulsions due to unknown cause. We can suspect B5 deficiency. B6 deficiency. And in B5 there are 2 typical features, which are burning feet and muscle cramps. If the patient complains of muscle cramps and burning feet, we can suspect B5 deficiency. And B6, we all know that it is responsible for bringing about convulsions in the child. Next is B12 cobalamin. It is responsible for megaloblastic anemia and developmental delay, regression, irritability. Next, B7, it is termed as biotin. As you see, the role is as a cofactor for mitochondrial functions. Mitochondrial functions means cell metabolism. At the cellular level, this is required. It results in dermatitis, conjunctivitis, thinning of hair, alopecia, CNS lethargy, hypotonia, seizures, ataxia. And B9, folic acid. We all know that during antenatal period only neural tube defects can be prevented with the supplementation of folic acid in advance, and it causes megaloblastic anemia. The pictures shown here are of first is of chelosis, angular stomatitis, and second one is of pellagra. There is typical pigmentation of skin visible on forehead and neck region. Next, B5 deficiency. These are the typical presenting features we have enlisted earlier also. Generally, next. Vitamin B supplementation can be given as a vitamin B syrup in children. There are no set standards, though there are adequate intake and recommended daily doses are mentioned, but there is no specific no specific supplementation schedule. So we can give simple vitamin B syrup to children if the signs of deficiencies are there. Now, vitamin C deficiency causes scurvy. Scurvy has become a rare disease, but it does exist. It is a disease of 6 to 24 months of age, and one of the causes attributed to scurvy is not providing fruit juices or fruits to the child, as it leads to deficiency of ascorbic acid, which is required for collagen synthesis. Collagen is very much important for in keeping the mucosal membrane intact and binding the tissues. Next. The features include irritability, loss of appetite, low-grade fever, and there is musculoskeletal pain and tenderness is in legs. So there is swelling of knees and ankles also. Due to tenderness and pain, the child takes a typical pose and it does not move. It is called as pseudo paralysis or a frog-like position. Costochondral bedding is also present here, but the difference between costochondral rosary is between costochondral rosary of rickets and scurvy is different in the sense that costochondral rosary in rickets is round in shape, and in scurvy it is angular. There are it is a little bit pointed. Sternum is depressed, and spongy gums and bleeding gums are seen in older children and in later stages of scurvy. Anemia is also there as vitamin C helps in absorption of iron. So lack of vitamin C results in anemia. Next. Vitamin C supplementation can be given, and we can apply the fundamental of Ayurvedic Palaprashan Sanskar in children prescribed by Acharya Kashyap. It is very scientific because introduction of fruit juices at the age of 6 months is related to providing polyphenols and flavonoids, which are very much useful for maintaining or maturing gut flora. As we know, a child has immature immune function, immature gut flora. That's why the child cannot digest everything given to him. So maturation of gut flora is very important, and Palaprashan can help a lot in it. Next. Now coming to micronutrients, mainly iron, zinc, calcium, electrolytes, and iodine. There are some others also, but due to shortage of time, I have reduced them. Next. Iron deficiency anemia is a very common presentation in children, and as a developing country, we face it as a very common OPD problem. So iron deficiency anemia is common in 6 months to 2 years. HB less than 11 gram per DL may be considered as anemia. There are classification of anemia according to ICMR. Mild anemia is categorized as 10 HB 10 gram percentage or more. Moderate anemia 7 to 10 gram. Severe anemia less than 7 gram of HB, and very severe anemia less than 4 gram per DL of hemoglobin. Now the sources of iron, as you see, meat, poultry, fish, but for the people who are on vegetable veg diet, they do not get sufficient iron supplement. So what we can complement from Indian food also, like beans, kabuli chana, rajma, nuts, lentils. Lentils is to be used along with vegetables. Dried apricots, figs, raisins. These dried apricots, figs, raisins are a little bit costly. So we can advise the patient to take jaggery and peanut. This is a very simple formulation for increasing hemoglobin. Next. Clinical features, if there is a moderate anemia, mild anemia, mostly asymptomatic patient comes to us. And if anemia is visible, it manifests as pallor, lack of stamina, patient complaint, mother complaints generally, child gets tired very soon, it is lethargic, it is very irritable, chid karta hai, this is the complaint. And there is a habit of pica. And the child earlier good in studies starts lagging behind in studies in school. So cognitive development may be affected in severe anemia, but it is reversible. Koilonychia, in severe anemia, koilonychia means depression of nails is seen. Next. Diagnosis according to WHO cutoff value, 6 months to 6 years, less than 11 gram percentage, we can label it as anemia. And if it is less than 12 gram percent between 6 to 14 years, we can label it as anemia. Investigations, we can do CBC, serum iron, and we have to do, we can advise the patient stool test for one cyst and for hookworm and occult blood. History of blood loss has to be taken into consideration. It may lead to anemic condition, and dietary history. Overall nutrition is also responsible. Next. Prevention is better than cure, as Ayurveda propagates. So maternal supplementation during ANC period leads to good storage of iron in neonatal period. Full term baby is, if the baby is full term, we can give supplements in the form of 1 to 2 mg per kg from 6 months up to 1 year. And if the baby is preterm, 2 months onwards, we have to start. There has to be deworming treatment, and we have to take control of pica, and iron rich fortified or fortified food can be provided, use of vitamin C rich food. While treating iron deficiency anemia, we can go for Ayurvedic drugs in a very good manner. We can opt for Amalki Rasayan, Swarnamakshik Bhasma, Bilva Magaj Churna along with Dadima Leha. But before starting this treatment, I again repeat that Agni Dipan Chikitsa has to be done. And for pica, what I generally do is, if the patient is not able to resist the habit of pica, I generally give some Ayurvedic powders or some tablets which taste like soil to the patient, and I tell the mother, isko chaatne ke liye de sakte hain aap. So it also provides nutrients and also relieves the habit of eating other non-useful things. Next. Treatment includes, modern treatment includes orally 6 mg per kg per day of elemental iron for 3 to 6 months. For 3 months, if given for 6 mg per kg and the normal level has been achieved, we can reduce the dose to 3 mg per kg so that additional supplementation can be deposited in the body. And IV iron must be avoided because it has some adverse effects. And severe anemia, if is persisting, we can opt for blood transfusion, and most safe method is iron rich diet advice and dietary changes advised to mother. Next. Now coming to zinc. Zinc is a very, very vital element. Like vitamin A, zinc also has a major role to play in immune functions. It also plays a role in growth and development. It acts as a catalyst for more than 100 enzymes. It interferes with iron absorption. It is very important for immune function. Ayurveda also says that Yashad Bhasma is Balya. In many places, Ayurveda uses a term Balya. Balya can be correlated to immunity boosters. So Yashad Bhasma is a very good immunity booster. Sources are meat, legumes, whole grains, fortified cereals. Pumpkin seeds is a good source of zinc. Almonds, cashew, walnuts. Even for getting required amount of zinc, we can opt for jowar, bajra or ragi, which we are forgetting, or we have forgotten a lot. We are not preparing these cereals. Till sesame seeds are also a very good option for taking zinc. And it has been observed that respiratory and diarrheal disorders, while treatment, if we give Ayurvedic medicines along with a little bit of Yashad Bhasma, it yields very good results. Next. These are the daily requirements, and upper limit is also given. We should not exceed this while giving Yashad Bhasma. Next. Next, coming to calcium, it has a major role in bone and teeth formation, bone growth, resulting in body growth. It is also important for blood clotting, muscle contraction, nerve transmission. Sources are milk, cheese, yogurt, broccoli, tofu, and a very good source is nachni, ragi. Ragi is very rich in calcium, and ragi can be advised at the time of weaning. Paste of a semi-solid paste of nachni flour is advised to patients to parents for starting as a top food. Rajma is also a good source. Kabuli chana, especially cholai ki bhaji, chavli leaves are very good source of calcium. It has been included as Agrya Sangraha Dravya. It is preferred than other vegetables, leafy vegetables. So it is a very good source of calcium. Next, this is the daily requirement, but still there is not a consensus, not a fixed amount of calcium which is to be given. Recently in January 21, WHO has conducted a meeting for establishing set standards for providing supplementation of calcium and zinc. Next. Deficiency of calcium results in adverse bone effects, poor appetite, muscle cramps, weak fingernails, cracking nails, tingling and numbness. And when there is prolonged calcium deficiency, the teeth become yellow, fractures in bones appear, growth and developmental delay is seen, mental confusion, depression and irritability is also seen in advanced cases. Next. While supplying calcium supplement, we can opt for Ayurvedic medicines, some branded medicines like Asti Pushtak Vati or Kukutandatok Bhasma are good sources of calcium. Those who cannot tolerate modern calcium preparations, we can advise them these medicines. And for getting calcium, milk is better than buttermilk. Both are sources of calcium, but milk is richer than buttermilk. Iodine is a very important thing in the spectrum of iodine deficiency, as you can see from fetal abortion to child and adolescent diseases. It can cause abortions, stillbirths, congenital anomalies, increased perinatal mortality. Infant mortality is also one of the cause. Cretinism may be caused due to iodine deficiency, mental deficiency. Basically, iodine is the means iodine supplementation is a very good option for preventing intellectual retardation. In neonates, it can cause neonatal goiter, neonatal hypothyroidism. In child and adolescent, it can cause juvenile hypothyroidism, impaired mental function, and retarded growth and goiter. Next. Deficiency of iodine stimulates thyroid, and thyroid stimulation leads to T3, T4, TSH elevation, and it affects growth hormone also. So it leads to growth, delay in growth, and it result in thyroid hypertrophy. And if prolonged, deficiency is prolonged, then it leads to hypothyroidism, which has its own consequences. Next. Use of iodized salt in pregnancy and later can prevent the consequences. Most common cause of preventable intellectual impairment is iodine deficiency. So the iodized salt has been promoted for many years, but it has been observed that increased iodine intake is also has also emerged as a cause of goiter. Next. Now coming to last 2-3 slides, we have to look into the prevention of nutritional disorders. In place of treating the nutritional disorders, we must choose for prevention. So prevention starts with increasing literacy, especially females should be educated. They should be advised regarding their health, regarding the health of child, regarding nutrition, nutritional values, preferable diet, and they should be guided with weaning method, proper weaning age, proper weaning foods, and eliminating unemployment is also one of the factors which can help in prevention of nutritional disorders. We are a developing country. There is a lot of population under poverty line, so they cannot afford to afford a normal diet also. So there is going to be a lack of nutrition. So socio-economic conditions needs to be improved. Family planning is also must, so as to improve the quality of food and division of food among children. Fortification of food is also a good choice, and increase crop production. If the crop production is increased, it can help in cheap supply of food. So it can help in reducing nutritional disorders. And when we consider Ayurveda as an option, we don't know what is working at what level. So there are many things which we can do, like Garbhini Paricharya, as Kaya sir also mentioned that Garbhini Paricharya is responsible for the fetal outcome. So Garbhini Paricharya, Sushruta has a different stand. Charak has prescribed some medicine. The edible items that has been has been advised in Garbhini Paricharya may we don't know where at what level they are acting, but it may be they may be helpful in supplying some nutrients also. Then Lehan has been indicated in children. Lehan is a good option to provide supplements. Swarnaprashan is also a good option to boost immune function. So we should think in a collaborative manner, not only giving supplements according to modern treatment, but we have to take it as a whole. From the beginning, we have to take into consideration the, as sir said, Suprajanan, we have to think of it. It should not be accidental. It should be a planned one, and it should be a prepared one. Pregnancy should be planned according to Ayurveda. So it can help in many things. The outcomes may be different. Outcomes may be more healthier. So Ayurveda definitely plays a role in prevention of nutritional disorders. And when the patient comes to our OPD, it is a good opportunity for us to guide the patient regarding diet and dietary items. Many less educated mothers or even highly educated mothers are not aware of which food should be given to the child and which should not be given. So there comes our role. We have to give advice, and we have to create awareness regarding nutrition and healthy food. Next. So take home message is a proper advice on weaning, monitoring of child growth coming to visiting our OPDs, and good counseling of parents regarding the diet of children, and growth promotion efforts we can implement. This is all from my side. Thank you.
Thank you so much, ma'am, for covering such a vast topic and for giving informative and knowledgeable presentation, which definitely helps us while treating nutritional disorders in children. So moving towards question answer session, we have some questions from participants. The first question is there any relationship between Agni and nutrition?
Relationship between
and malnutrition?
Agni. Yes, definitely there is a relation between Agni and nutrition. If the Agni is not functioning properly, the digestion will be impaired, the absorption will be impaired, the excretion will be impaired. Agni may be Jathara Agni, or maybe at cellular level, or maybe at molecular level. Definitely there is a role of Agni in nutrition.
Yes, ma'am. The second question is, What difference should be kept in mind while advancing diet to an immunocompromised child from a normal child?
A immunocompromised child needs special care. A normal child can tolerate the things we provide to him, but immunocompromised child, we have to take into consideration some special food items which may not interfere with his immunocompromised state. So it depends on patient to patient what type of immunocompromised state is there. So we have to select it according to the individual.
Okay, ma'am. Thank you so much for such an informative and knowledgeable presentation. I request Honorable Dr. Vijay Kumar Gawai, sir, to give concluding remarks on this session.
Thank you, ma'am. Can you hear me?
Yes, sir.
Can you hear me, ma'am?
Yes, sir, you are audible.
Okay. So, firstly, I congratulate Dr. Datta Patil and all Commonwealth Department and Dhanvantari Medical College for arranging this informative seminar on nutritional disorders in children. I also congratulate Dr. Yogita Srivastava ma'am. I know very well. She is a good academician and clinician. उन्होंने बहुत मेहनत की है इस सेमिनार के लिए. ऐसा लगता है उनके लेक्चर से उन ऑलमोस्ट all part of disorders she touched, like from definition, types, PEM, classification of PEM, difference between marasmus and kwashiorkor, diagnostic methods, clinical methods, difference between marasmus and kwashiorkor, management according to modern and Ayurvedic was also very good. Then obesity, vitamin deficiencies, particular vitamin A deficiencies, rickets, decomplex, deficient diseases, vitamin C, scurvy, micronutrients, iron deficiency, anemia, zinc deficiencies, calcium, iodine deficiencies, and important part was prevention of nutritional disorders through Ayurveda. So everything was very informative. I congratulate ma'am for this. Second thing, I congratulate you, Dr. Anil Kayale sir. I attended his lecture. It was very informative. I congratulate Dr. Datta Lote sir. And lastly, thank you very much from my side for Dr. Datta Patil and entire team of Dhanvantari. Thank you very much.
Sir, thank you.
Thank you so much, sir. So moving towards the last part of this national webinar, vote of thanks. A very good afternoon, everyone. I'm here to present vote of thanks. I would like to thank our inaugural guest, Honorable Dr. Zubair Sheikh sir and Honorable Dr. Santosh Neupurkar sir for inauguration of our national webinar. I would like to thank our chairpersons, Honorable Dr. Dattatreya Lode sir and Honorable Dr. Vijay Kumar Gawai sir for joining us with their knowledge. I would like to thank our guest speakers, Honorable Dr. Anil Kayale sir and Honorable Dr. Yogita Srivastava ma'am for giving their valuable insight and such an informative and knowledgeable presentation. I would like to thank our principal, Honorable Dr. Dattatreya Patil sir for giving permission to organize this national webinar. I would like to thank Dr. Avinash Jadhav sir, Coordinator Academic Committee, HOD and Associate Professor, Department of Swasthya Vitta, for helping us in easy and smooth conduction of webinar. I would like to thank Dr. Deepika Bhadre ma'am for helping me in hosting today's webinar. Also, I thanks to all participants, UG, PG students, teaching staff, medical officers and practitioners for joining today's webinar. Thank you so much.
Thank you, Dr. Bhadre. गवई सर धन्यवाद. काय चाललंय? संपलं वेबिनार संपला आता. श्रीवास मॅडम नमस्कार. थँक्यू व्हेरी मच.
थँक्यू सर मला चान्स दिल्याबद्दल.
थँक्यू नाही मॅडम, थँक्यू थँक्यू थँक्यू. येस, बाकी निवांत. येस, थँक्यू मॅडम, थँक्यू वन अँड ऑल. ओके.
Feedback link has been shared in the YouTube chat box. Please fill the feedback form so that e-certificates can be generated. E-certificates will be sent to your email ID on 9th April. On 9th April, the certificates will be issued. Please check your inbox. If a certificate is not in the inbox, it will be in the spam folder. Certificates will be issued from email ID webinar@damchudgir.edu.in, so that you can search this email ID also. Thank you for joining us.
Thank you, everyone.